Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
Good morning, good afternoon, whenever you're listening to this. Welcome to another episode of Health Law Talk, where we give you the latest and greatest of health law. Rory, Bellina, Conrad, Meyer. Good morning, Rory.
Morning. How are you?
I'm good. I'm glad it's Friday.
Yes.
I'm glad to be here. I like doing this. I really do. We've been doing this now. I think this will be our 60th episode. So 60 episodes.
Yep. Yeah.
I mean, that's, I know we kind of had a lull last year, but I'm glad we're back.
Last year was a busy year. We got distracted, but we're back. We're committed to doing this on a weekly basis, hopefully, and we'll just keep this going.
Absolutely. And you know what? Today is really, really timely topic. I mean, it just happened 2 days ago. President Trump comes out with the great healthcare plan.
Yep.
You heard about that?
Yes, I did. That's what we're going to talk about today. The great healthcare plan. Right now I know that it's getting a lot. It's a framework essentially that's gotten a lot of attention.
Right.
Kind of a lot of confusion in the national media, and people are curious what it includes. So we're gonna go through that.
And that's everything's great, right? Everything's got to be great. Great healthcare plan. Great.
Great's the.
And look, I think we're on a roll, but I get it. That's his language. That's his mantra. But I'm very curious to see what's behind the language, right? Because that's going to be where the details matter, right? Details matter. So Roy, walk us through. Give us at a high level. What are the four things that are going to comprise the great healthcare plan?
So just so everyone is clear, right now this is just framework. It is
talk.
Yeah,
it's just talk.
Not actually a law yet. Congress would need to pass this. We don't know if or when that would happen. A lot of healthcare experts are skeptical about how much is actually going to make it through, but yes, the plan does signal where we're heading, and so that's what we're going to go over. So like you said, 4 pillars, and then we'll break down all 4. Pillar number 1, lower drug prices. Obviously an easy one as a softball for everyone.
But wait, what does that mean when you say lower? How do we do that? What's the high level?
Okay, so we'll jump right into the first one. Or I'm going to rattle off all 4, and then we'll kind of go into it. So,
go ahead. That's fine.
All right, first one is lower drug prices.
Okay.
Number 2, lower insurance premiums. 3, hold insurance companies accountable. Very broad statement.
That's right.
And 4, maximize price transparency.
Why do I feel like I'm hearing like an election speech? I mean, don't all politicians
come out with big ideas,
or they just say this? We're gonna lower prices and get high quality.
Right.
I mean, I hear that. I've heard that for 30 years.
I know. Well, let's take them one by one, and we'll go over what the outline looks like, and we'll see where we get. So for lower drug prices, kind of the bullet points for that is this most favored nation, this MFN pricing, where the concept is that Americans would pay the lowest price for drugs than any other developed nation would pay.
Love that. I think that's a great idea.
According to the White House, they have 16 pharmaceutical companies, including Pfizer, AbbVie, that have already signed on to this, and the plan would make these mandatory through legislation.
Nice.
Another kind of high-level point on this is expand over-the-counter drugs. Most drugs available, obviously everyone knows what an over-the-counter drug is, but expand that so that not too many require prescriptions, so then you lower the barrier of actually having to go to a provider and get that prescription. And then lastly, under
I love this one
category, the TrumpRx.gov website.
Why does he have to have his name in it?
I didn't have to look in. Well, it's his legacy. I didn't get to look and see if the website is up or if the domain is taken. I'm going to try to look.
Yeah, look at it.
I'll try to look.
Yeah, I want to see if it's taken right now. But I mean, it has to have his. Why couldn't he just say like USA something?
Yeah, the website. It is.
The
website's available. It just says.
He got it.
Coming.
Wait, go back. He's got his picture on it.
He does.
Wow.
It's an official website of the U.S. government.
I love Trump.
Coming soon.
I mean, like, because he's so magnanimous. He's got to have his picture, his name, and everything. Anyway, go ahead.
We'll see. We will see if this goes anywhere. But
would you expect anything less?
The website's there. The goal with this website is it's going to be a platform for cash-paying patients to buy discounted drugs.
Really?
Yeah.
Interesting.
So, all right, number 2, we said it once, lower insurance premiums.
This is like a staple. I've heard this for 50 years.
I know.
Jesus.
So instead of paying subsidies to insurance companies, the goal would be to send the funds directly to Americans, maybe through an HSA. I already have concerns with that, because if you send subsidies to people and they're going to
spend it.
They're going to spend it. They're not going to save it. They're going to spend it.
They're going to say it's free money and we're going to go to the casino, and then all of a sudden they're going to say, well, wait a minute, what happened to that money, right?
Right. You're supposed to save that.
All right.
All right. This other thing, it is called a cost sharing reductions, a CSR. So
yeah, I've never heard of this.
The plan is that this would save taxpayers $36 billion over a decade, and it would reduce those silver plan premiums, which were under the
we're going to have to see what that's about.
Right.
All right.
And then this one is always interesting. This is coming up. We talked about this last week, and we're going to do a couple of special episodes on it. PBMs. The goal is to end these PBM kickbacks, stop payments for PBMs to brokers, which inevitably is raising.
I can't wait till we do that. I am so looking forward to that. That's going to be yes, absolutely.
Number 3, we said hold insurance companies accountable. What does that mean? Require clear, understandable policy language. I think that's easy.
You think it's easy? I mean, we've read those things. Do you think the common person could read?
I know.
I mean, it is very, very difficult.
And then also under that is insurers must publicly post.
Now, I like this.
Yes.
I love this.
Their medical loss ratios, which is...
Because this was supposed to be in the ACA, right? It was supposed to have...
And I don't think it made it. I think it got pulled at the end.
Right. So I would really like to see the medical loss ratio, because that's going to tell you how much premium is being paid to the member.
On care.
Versus administrative.
Correct. Yes, correct. Exactly. Claim denial rates, average wait times for care.
I love that. Boy, that's going to be great. You know what? They should put that publicly on some website that they have to do it so everyone in the world can see it. Boy, would that be great.
And then a penalty provision if there's non-compliance penalties.
For posting it? I don't know. We have to get into that.
Yeah, I don't know.
But wouldn't that be great? Because you walk, like you drive down, I'm going on a tangent here, but you drive down the highway and you see the ER wait times.
ER wait times,
right?
yeah.
So you see, this ER's got a 10-minute wait time. Wouldn't it be great to see medical loss ratios, claim denial rates for the major all over the country?
Yeah, absolutely.
I think that would be great.
Absolutely. Because then you could really compare what these different payers
I guarantee you they don't want that.
No.
I guarantee you.
And then maximize price transparency was
the
fourth one. A mandatory posting of any provider or insurer that is accepting Medicare and Medicaid must post pricing and fees at their place of business. Right now, they're supposed to place them online.
Right.
I think this was in Trump's first term. He had some requirements where hospitals had to post their prices for different things, different procedures, surgeries. This allows patients to essentially shop for care.
So we want to be clear, though, to everyone listening that this is not a replacement for ACA. So ACA is not going away.
No.
So this is just an amendment, or I guess a change in Medicare benefits, or it's just going to be changes on top of ACA.
Correct.
So people who are listening thinking, oh no, we got the great healthcare plan, it's going to take away ACA. No, that's not what it's intended to do. So.
No, the only thing that this ties in with the ACA is that I think that there's a possibility that it destabilizes the marketplace, because if you start to take these subsidies and you pay them directly to consumers versus the insurance companies, you might have defeated the marketplace at that point, because people are, like you mentioned, people are not going to save this money. They're going to use it how they wish.
I think historically they're going to do that, So we'll see. We'll see. Well, let's dive right into it. Talk about the most favored nation drug pricing. How does that work?
Yes.
Rory?
All right. So a little background on the MFN. This was tried during Trump's first term through an executive order. It was challenged and blocked almost immediately. So going back to May of 2025, President Trump has signed various executive orders and negotiated deals with these 16 large pharmaceutical companies. Now they want to codify these deals into law to make it mandatory and not voluntary. So how it would work is that the U.S. government essentially would pay for these drugs based on an index, I'm quoting the language, based on an index of prices from other developed countries, typically much lower than U.S. prices. President Trump claimed this would bring drug prices down 80 to 90% in some cases. So What do you think about that?
I think it's interesting. I don't know if you realize this. NPR just reported that all 16 companies that signed deals still raised their prices on 872 brand name drugs.
I'm sure
that was just a month ago, this month.
Yeah,
we're in January. So the median increase was 4%, same as last year. But if you look at it, are we really going to see decreases? Are we really going to do that when year over year we're seeing increases?
Yeah, I don't know. I know that these different research firms on drug prices saying that although these deals have been made,
right,
we're still pretty much in line with the raises, which seem to be around 4%.
But we don't. The problem is we don't know the deals; they're all secret.
I know.
We can't see them.
I know. Yeah, and these discounts for this TrumpRx.gov website, that's going to be for cash-paying patients. So it's not going to necessarily apply to using your Medicare benefits or your Part D in this case.
So what are we seeing in Congress? What's going on there? 'Cause it's got to go through Congress.
It does. I know that our Speaker Johnson, I should say, does not like this MFN pricing. We don't have a lot of information why, because this is very new.
Okay.
But I know he came out and said he was not a big fan, and there would be more information on that. And then there was a lot of exclusion from Republican lawmakers in this reconciliation mega bill that we plan to see. The other thing is that there's no true blueprint for what this would look like statutorily. I don't know how you're going to do this.
And where would you put it? You're
regulating private companies on drug pricings and deals that they have to make. I'm not quite sure. I'm not quite sure where we're going to go with it, honestly, or how it can be implemented.
So here's what I want to know. I'm sure the industry is already opposed to this. Big Pharma is probably no doubt would argue that MSN pricing would threaten research and development. I mean, that's the first thing they're going to say. So you're going to lose a lot of money for R&D. It would undermine access to cutting-edge therapies. I mean, I guess that goes along with R&D. They're going to say that too. They're going to also look at this 1-2 punch to innovation. So with combined IRA drug pricing negotiations, you're not going to get. I think the innovation is going to go away.
Right.
You're not going to get. You're not going to get new drugs like you see on TV all the time, I guess. And then of course they're going to say this really isn't our fault. It's not us. It's the PBMs, which we haven't got to yet.
Right.
We haven't got to, but we're going to get to shortly.
So from a Louisiana perspective, I think that everyone should just know that this is just what President Trump and his administration wants. I wouldn't expect anything immediately to happen. It's important for physicians and pharmacists to watch the different formularies. So if some of these drugs do get cheaper, I would expect the pharmaceutical companies they're not going to want to lose their profit. So if they're going to be mandated to make certain drugs cheaper, are they going to make other drugs more expensive? I'm just guessing. I'm not quite sure.
Well, we'll have to see what happens. Well,
and then when this website launches, now it's in a coming soon phase.
Yeah.
Is there going to be some cash discounts for uninsured patients? And we don't know how this would affect 340B. That's a wild card as well.
I hear you. Well, let's go to the next thing.
Okay. All right.
Direct payments, ACA. So I mean, this was a big controversy, big deal. So Rory, walk us through.
All right. So this is the most controversial portion, I think, of this whole plan is to send the premium subsidies directly to the consumers instead of the insurance companies. Sounds somewhat good in theory. Who wouldn't want the money sent directly to them instead of the insurance companies, so that they could decide maybe they're going to invest it, maybe they're going to put it in a market account and earn a little bit of interest on it. But where could this go wrong?
I think people get free money.
Yeah,
and
then they don't spend it.
They spend it and they don't put it where it's supposed to go. Right.
Correct. Because then the concept from the administration, the current system is that let's back up a step.
Well, they're going to put it through HSAs, so they would be limited because if they don't spend it on healthcare, right, then you get taxed on that.
We think they're going to put it through the HSAs.
Oh, we don't know.
I don't think we absolutely know. We don't know if it's going to be a check to every American.
Well, this is so new. We don't know. We haven't seen the legislation.
Because right now these subsidies go directly to the insurers to reduce the premiums for low-income enrollees. The proposal is that the money would go directly to the individuals. We think through HSAs. That makes the most sense to me. But I could see an instance where it's either an offset on your income taxes or it's an actual check. I'm not sure. The President Trump's framing of this is that he wants to stop making the insurance companies, quote, rich and give money to the people. But the problem is that are they going to be responsible enough on saving?
I don't know.
So What are the problems that you've researched on this?
So I looked at this earlier, and basically the whole argument is that getting the premiums to the individuals would destabilize the marketplace.
Yeah.
So each individual state has its own marketplace. It was required by law. So healthier people might not buy expensive plans.
Right.
And so therefore, the whole point was, and I mean, going back to ACA, remember, it was, and people didn't realize this at the time, but the whole point of the mandated coverage was to get young people to buy in,
right,
to help fund the people who are old and getting sick.
Right.
That was the whole point. And then when that got struck down, right? So now you have a gap. That's why it failed, or it's not. I guess not optimal, if you want to call it that. So people give him the money directly. Well, I'm just going to get the cheapest plan, and I'm going to pocket the money for the rest. I'll just save it for a later date, maybe a deductible or what have you. So it could leave sicker people in the ACA marketplace, and it will drive up premiums. Yeah. Not good. Not good. One of the things that it would be, like you said, how do we administer this? Monthly payments, advance payments. How do you true up? How do you reconcile? Again, we don't know. I did see something about this pre-existing condition protections if you go outside the ACA, but one thing I want to comment about that, HIPAA has some language about coverage on pre-existing conditions. If you could look at that up, I know that sounds crazy, but if you look at the HIPAA regulation itself, there is a prohibition on pre-existing condition, but it's deep. It's not in the regular where you're thinking about PHI. I'll show you that.
Okay.
So, and then of course we have no idea.
Right.
We don't know. Right. Nobody's written this yet. This has just been pie in the sky.
Right.
It sounds good, right? So. Let's talk about this. The enhanced premium tax credit debate, Rory. Sure. I know you looked into that. Tell us a little bit about that.
Yeah, so this is what's make this kind of urgent, I would say, is that and I think we talked about this last episode, the enhanced premium tax credits that made ACA coverage, quote unquote, affordable, expired December 31st, 2025. So on average, I think analysts are estimating that about 22 million Americans are going to face a premium increase for calendar year 2026. There's been various reports of people having to make big choices on how they're going to handle these premium increases. The House passed a 3-year extension, but only 17 Republicans supported it, so it was essentially dead on arrival on the Senate. President Trump's plan at this point does not address this. It's a whole new structure which is going to take time to figure out, and we know that the Senate is working on a bipartisan compromise, but we still have this enhanced premium tax credit rebate that ended that we don't see is going to get renewed.
So what does this mean for Louisiana, Rory? How do we fare in this?
Well, I would say the concerns are if you are on the hospital side or on the provider side, I think you're unfortunately going to see people that can no longer afford their insurance and are going to have to go back to the ER model, essentially, the hospital model. If you can't afford it,
the charity
premiums,
system. It'll be the charity system of the old.
You drop your coverage, charity care increases, that people are going to seek free or reduced care, so the ER wait times are going to go up, quality of care. We're going to have issues. You're going to have more debt on these hospitals. That would be my concern, is that we're going to have a little reversion back to that model.
So let's dive in on the next pillar. Okay. Price transparency.
We've heard this a lot.
Yes, we have.
Yes. All right,
and look, I like it. I think it's a great concept.
Yeah, the first administration really pushed for this, especially for the hospitals. But so what's different here?
Oh, well, okay. So according to the 2021 current requirements, hospitals must post a machine-readable file with all prices. They must be consumer-friendly.
Yep.
Insurers must post in-network negotiated rates.
Yep.
Okay, and then you have the out-of-network allowed amounts, the prescription drug pricing, and there's penalties for non-compliance.
Right.
So I get that, and I forgot, what was it called? The name of that bill in 2021? Oh my gosh, I just looked at this. But
it had an acronym. It was
I can't. And it's we have so many healthcare acronyms. But anyway, all right, not a big deal. So, but what's in the new great healthcare plan? How does this change?
All right, we're expanding the scope. That's the kind of the theme of this, is that all providers accepting Medicare and Medicaid must post prices prominently at their place of business on their services. The penalties are going up. We don't know what they are right now. I believe it was $300 a day for hospitals. We know that the plans are going up. The penalties are going up. The plain English standard. Insurance companies must use clear, understandable language.
That's right.
And then again, what you mentioned before, posting the rate and coverage comparisons, medical loss ratios, claims denial rates, average wait times. Providers must answer pricing questions clearly and upfrontly. So all very broad, grandiose ideas that we'd like to see, but we don't have the true language of what we don't know what is going to actually make it into the bill.
And that's the billion-dollar question. So,
correct.
So look at this. Cynthia Cox at KFF, which is a healthcare policy research group, said that this is not going to be a magic bullet.
Right.
That most patients don't shop for healthcare; they go where their doctor tells them, and I would agree with that. I mean, most doctors are going to say, "Oh, go here, go there." Patients who aren't, I guess, consumer savvy would just go with that because they trust their doctor. The white coat syndrome. There's an unintended consequence. Some hospitals have used transparency to negotiate higher rates from insurers. So what they do is they go and they put them on, and then they look at their competition, right? And then they go and say, okay, when my contract's up for renewal, we're going to negotiate higher rates.
Yeah.
So it's
why is the hospital down the street? Why are you paying them?
Correct.
Why are you paying them $100 more for this? I see.
Right. So probably, and so that's going to be an issue.
Yeah.
Probably a relatively small share of healthcare spending that is able to be moved to price transparency. So maybe a smaller sliver. And of course, elective procedures like cosmetic surgery, fertility, things like that, where patients shop might be carved out. So, you just have to see about that.
So right now, it's just important if you're listening to this and you run a hospital system, make sure you're complying with the current regulations, that your prices are posted, they're accurate, up to date, easily accessible. This physical posting requirement, we don't know what prominently post really means. It could mean signage. It could be more than just the website, which is what's required now, which makes it difficult to update it. Getting your front desk staff familiar with this so they can answer the questions clearly and up front. And then if the penalties go up, obviously be aware of that. CMS is going to have to address this. That's where all the details are going to be in this. So we don't know what that looks like, but this is the plan.
Well, I like the plan. All right. Well, moving on. So PBM reform.
This is I think if there's one thing that could happen, I think we're getting so much pressure on PBMs from a national and a Louisiana state level.
100%.
That this is really where we need the movement. It's been in Baton Rouge on PBMs lately. Our last episode was all about this. So there's bipartisan support for PBM reform. I think this is the one thing, if you had to pick out of this list of pillars, I think this is the one.
So what does the Great Healthcare Plan say about this?
All right. Well, the proposal is, and the phrase used was kickbacks, which you and I could go down a different topic on if is that the right term or not. But end the kickbacks paid, their words, not mine, end the kickbacks paid by PBMs to brokers. So what does that mean to you if you hear that?
Well, it tells me, if I'm wearing my healthcare hat, if I get kickbacks, that tells me there's some sort of a scheme going on. Mm-hmm. There's some sort of a scheme where someone's making money, right, inflating prices to take a cut because they're, either they're entitled or they feel entitled or they just want more money. I mean, that's a kickback. I mean,
because the concern is that these kickbacks, these fees/rebates that are going to the brokers are inflating the insurance costs, and it's really not benefiting the patients. So, the PBMs are saying, no, this reduces costs, and you need to blame the manufacturers, which, I don't think is the case at all. So, what Congress has already passed as of this month is this transparency requirements for Part D. This Part D delinking, which is discusses separating PBM compensation from drug prices. Medicaid spread pricing ban, where PBMs can't profit from the spread between what Medicaid pays and what the pharmacy receives, which is very interesting.
But that's what they're doing.
Yes, and then some changes to network access standards. So PBMs is, I would say, the one that I'm the most interested in for all of this, because I think that prescription drug prices affect. Obviously, insurance coverage is very important, but drug prices really do affect everyone.
But it's not just prescription. I mean, they have the OTC. So the over-the-counter drugs are going to be more available.
Making more actual drugs available over.
Correct.
Yeah, our current administrator of CMS mentioned that there are a lot of drugs.
Dr. Oz.
Dr. Oz. That he mentioned that there are a lot of drugs that are on the prescription schedule that should be over the counter. Benefits of that, obviously, you don't need to go to the doctor to get the prescription. Competition, because if it's being made as a generic over the counter, you're going to have all these manufacturers vying to make the same thing. and it's going to reduce your insurance costs because now your insurance does not cover over-the-counter drugs. So it's
the only problem with that is you're going to have FDA issues because the FDA is going to have to analyze all this and see what prescriptions can go to OTC, and that's going to take a little bit of time. But I can see the benefit of that.
And on the flip side is that, if you move it from prescription to OTC, now your insurance doesn't pay for it. Well, what if it's very expensive over the counter and people relied on their insurance paying for it, and now they're going to have to pay cash for it because insurance doesn't pay for over the counter?
True.
So what if you got one of these NSAIDs that Dr. Oz wants to move from prescription to over the counter? He does
then
that.
You just have market dynamics. I mean, they just won't sell.
Right.
So if they don't sell, then you have to. You have to adjust your
But if
price.
it's something that a patient relies on and now it's over the counter and it's $100 versus prescription, their copay was $10, I think that's a concern. That
is a concern. Maybe there's some regulatory constraints on it. I don't know.
So what's going to actually happen here? And there's been some experts that are saying what the likelihood of this plan becoming a law is. We've got some of their different quotes that we've got. What are your thoughts on that?
So, interestingly, Spencer Perlman from Vita Partners talked about this. Less more of a plan was the comment, but more of a political press release. And I could see that because we don't know anything about it.
Yep.
And so the thought was that the policies either have little chance of being enacted, given the gridlock in Congress, which we see all the time. Jim Potter for the Coalition of Healthcare.
Same thing.
Yeah. Same thing. This is just political grandstanding.
This is one of those things where when you read it on paper, I think we were talking about this before we started recording, it sounds like when you hear any president, doesn't have to be President Trump, any president address the nation, they say, I'm directing you, Congress, to do this, to do that. And he looks over and they pan the cameras to everyone in Congress sitting in the diet.
Now what?
And then it's, I'm directing you to do this. I'm directing you to do that. And they're all sitting there like, yeah, sure, we have to do the hard work.
Wait, I want to tell you something. I want to pivot for just a second, okay? And here's my thing for this. I don't think our listeners or even the American people know how that works. Right? In other words, they hear these people, whether it's the president or any politician, right, stand up and say, what do we hear? We're going to lower costs and get an increased quality. We want to give you this, right? And it sounds good. It gives you warm fuzzies, right?
My first 100 days in office, I'm going to get this accomplished.
Yes, and I got warm fuzzies, and I think it's great.
And that's who you vote for. You vote for the ideas that you hear.
But here's what happens. Those congressmen, right, and those senators, they have what they call draft writers. Okay, these are people who are supposedly nonpartisan, that are responsible for drafting the legislation. Right. They are the ones that sit in an office, take the statute, and draft this thing.
Right.
So when you hear a plan like the Great Healthcare Plan, I guarantee you, those drafters are
hitting their head against the wall.
What are we going to? This is going to be a massive project.
Right. Or they're sitting in their office saying, this is impossible, and here's 50 reasons why we can't do it.
Right.
And so you're right. It's hearing an idea and then executing the idea, two completely different things.
And then when you see it on TV, like it's some massive 1,000-page bill, and then you hear the senators or the congressmen or women saying, we need to pass it now, but you haven't even read it.
Right.
You don't even know.
Right.
I mean, I bet you if we sat down, the only people that really know are the people who drafted it.
Yeah, and the staffers that are forced to read it.
And give them talking points.
Digest it to the senators. Right. No one's reading all that.
Do you honestly think that's a good way?
I'm
just asking you. Do you think that's?
No, I don't.
I think that's great because you're binding 300 million people.
Yeah.
To this.
To something that you have not read. Yeah.
And you just got talking points on a bullet point sheet to stand up on a grandstand and talk about this.
And then it gets challenged to the Supreme Court. And
correct.
Then,
Anyway. So what else? Okay, so wait. What actually might pass, Rory?
I think PBM reforms, if you said, Rory, pick something on this sheet that's going to pass, PBM reforms, that's got bipartisan support. Some have already passed in appropriations. That's very important to the American public and to Congress.
I think you're right on that. I think you're right. What about price transparency?
Maybe through like a regulatory action. I don't know if it's going to pass through legislation. I could see it going through a regulatory agency, which would be a whole other topic on administrative law and how that works.
It'd have to be like the CBO, like a nonpartisan place, right?
Right. And then the CSR funding under Affordable Care Act. And then
that's the car sharing reductions.
Yes.
Okay.
And then over-the-counter drug expansion, that's more of an administrative action through the FDA as well, where they're manipulating the schedules and saying this was prescription, now it's over-the-counter.
But let me ask you this: I mean, given the lightning warp speed that FDA did during COVID, do you think they could do that with OTC?
I do.
I think so too.
I do. The FDA has been moving. I was reading an article last night. The FDA just requested or gave permission for GLP-1s that they are now allowed to remove the suicide warning from their packet on for GLP-1s. So,
wow. Okay.
So they haven't been around that long for them to. I mean, that's a big decision that's been made. So the FDA is, like you said, still moving fast. I think the FDA could handle this OTC drug expansion.
Okay, so let's flip. What do you think not going to pass?
All of it is not. It's not all going to pass together. I don't think there's going to be this one huge package. I think it's going to be piecemeal. I think we'll get maybe one or two things. Maybe the PBM thing this year. We might get something next year, and then some things may or may not happen at the end of this term or before the end of this term.
Right.
The direct payment structure. I don't see that happening. I think there's too much concern with the marketplace.
I know what it was in 2021. I found out the No Surprise Act.
That's where it was.
That's what it was. No, I told you. I didn't even look it up. How about that? The No Surprise Act. That's what it was. That's what it was.
So that's what I think. And then this codified pricing.
Yes.
I don't think that's gonna. There's too many variables to
the
codify.
Most favored nations.
Yeah. I don't see.
But he went out so strong on it. I mean, he really went hard on it.
I know, but like any politician,
but here's the thing. Wait, I agree with him though.
I know.
I mean, should we as Americans pay more than every other country for the same drug?
No.
And they make it here?
Well, a lot of the drugs aren't being made here. I think that's the rub, is that a lot of these over-the-counter drugs are being made in other countries.
No, I'm talking about prescriptions.
Oh, prescription drugs. Okay. Well, still a lot of them aren't made here. I mean, like your typical Tylenol, Advil, I know those are all made overseas. And we are paying more when they're shipped over here.
Interesting. Okay. I did not know that. Okay.
Oh yeah.
Interesting. Okay. So why does everything matter? Why are we here? Why is this important now?
I think from a cost perspective, even if this doesn't become law, it just shows what the priority is. And I think healthcare for everyone, America is an aging country. We've got a lot of people that are aging, and so costs are going up. Medicare costs are skyrocketing. Yep. I think Dr. Oz, he wants to ruffle some feathers.
It's not just that though. Insurance premiums. I mean, I feel like they do. Like, when have we ever heard of I think you and I talked about this off the record. But when have you and I ever heard of an insurance company coming back the next year and saying we're going to decrease you? Like,
right. No.
It's never. Never.
No.
Never.
No. It's not. It doesn't happen. So, it's a priority for this administration. We just have to see what actually gets accomplished. So, big on promises, details not so much right now, and congressional hurdles. So, what are your takeaways, Conrad, for our local providers?
So, for local folks, for our local Louisiana healthcare providers, don't expect dramatic changes overnight. This is going to be like watching grass grow. I mean, we're going to be watching a slow-moving train.
Right.
But I think you do prepare for what we talked about for the price transparency enforcement.
Yep.
I think you look at that. I would watch for formularies and financial programs as the ACA subsidy plays out, the situation plays out there. And stay tuned because, CMS rulemaking coming up this summer for the physician fee schedule and the inpatient IPPS and OPPS. Yep. So we'll have to see where things are going to go. But yes, I think we have to just watch out for what's coming up.
Yep. All right. That's it for today.
See, look, Rory, you closed out.
That's it. That's my closing. Yep.
That's your closing. Well, look, everyone, thank you so much for this. I think that's going to wrap it up. Thank you again for listening to Health Law Talk. Remember, listen to this podcast. Send us an email if you have any suggestions. Leave us that 5-star rating. We did a good job. We hope we did. See you again next time. Have a great weekend. Take care.
Thanks for listening to this episode of Health Law Talk, presented by Shahardy Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardy Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardy Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.